you talked a little looking in and making sure they're not progressing. So that maybe brings us back to something we talked about a little bit about before, but how important is that repeated pathological assessment, looking out for grade progression typically, right? The TA low grades becoming the high grades maybe, or so what would you find cystoscopically that would make you not want to continue with an ablative approach or really want to get that patient back into the OR?
So when we, because I was mentioning earlier, I do a lot of surveillance for these type of patients currently. We will also do a bladder wash at the time of our cysto, and we'll get right on top of the tumor and take a 10 cc syringe and go back and forth, and we'll see some fragments, come off the tumor and, some particles, and we'll harvest that. And our cytopathologists are really good at telling us whether there's any high-grade cells or not. So for me, that's my surrogate. If there's no high-grade cells, then I'm not so worried. If I see anything high-grade, or if the pathologist says something atypical or suspicious and they can't clearly tell me negative for high-grade, then in my mind, especially if the tumors have grown, especially if there's more of them, that's a patient I may want to take to do a formal TURBT because I want to ensure that it hasn't progressed. But a lot of times, if that washing is, clearly negative for high-grade cells, I may just continue to do surveillance on them.
Similar approach for you, Dr. Porten?
Similar approach. And I think it's, you can always get a small, like a biopsy of something in the office at a reasonable interval just to double check.
The only thing I worry about cytology, and I do the same, we try to get right up to next to the tumor and get those cells and stuff. But I worry about cytology, the sensitivity, even in picking up high-grade disease. We learned from the Flex Blue Light study, which was a prospective study looking at flexible blue light. These were mostly high-grade patients. Of the ones who were picked up by blue light alone, 0 of the 13 had positive cytology. There were many atypicals in there. Many of them were negative. Now you can say, well, these were probably small tumors, but nevertheless, we missed 13 tumors that were high grade on cytology. This was institutional, but not central cytology, but nevertheless. So I worry a little bit about that, but you can argue it's, if it's not showing up on cytology, maybe the biology is not as aggressive. But like Sima said, I think biopsy, sounds like we're all doing in-office
That's pretty straightforward to do, yeah.
So Dr. Porten, what you've alluded to, needing longer term follow-up of the trials we've just talked about, but what other information, do we need to gather as a community? What studies need to be done before we can change our treatment paradigm in this intermediate risk space?
Of course, mechanism of action, and I think sequential mechanism of action, kind of like you alluded to the MET-ONCs sort of thing. Well, what got resistant, why? And then what else do we have in our tools? But for this disease, I think this is where urinary biomarker space is really exciting, and you're starting to see a lot more out there and focus on looking at urine-based diagnostics, because it would be natural in the non-muscle invasive disease space that this would be a good focus for us and help us.
So you're talking about diagnostics? You're talking about for initial diagnosis or monitoring, both?
I think for monitoring, but also for looking at alterations and predicting response, which is a harder bar.
Yeah.
Yeah. I mean, it's an evolving area rapidly. I mean, we are now seeing some great data with circulating tumor DNA, and you're now able to extract DNA in the urine, reliably. And so we may define intermediate risk not by our visual appearance, especially we're talking about we can't really measure the size too well, but we might be defining it by a certain molecular profile based on the tumor in the urine. And that might allow us to better select patients for, either specific therapies or, some patient might be better suited for chemoablation versus other ones. So it's just, now that we have a drug and we have these tools, there's like a multitude of studies we can do to try to optimize the treatment for each individual patient.
There are newer biomarkers coming out which are quantifying the amount of tumor in the bladder rather than the traditional positive and negative that we're used to with the other biomarkers. So Pangea Laboratories Bladder Care is currently doing research, and they have a quantifiable result where perhaps, like you mentioned, as we look through the ongoing treatment, you can actually see the decline in tumor cells. We have a lot of opportunities to do that in the future. And nothing so far has been very useful, but I look forward to the future where we can actually try to predict these responses based on quantification of either tumor DNA or other methods with methylation markers and things like that.
You alluded to actionable mutations, and I think that's where you're headed. So what do you guys think about FGFR targeting in this space?
Yeah. Pretty hot topic right now, both in metastatic and it sort of spans the entire spectrum of disease from low grade all the way to metastatic disease. And interestingly, it's a reverse relationship, right? The low grade tumors have much higher FGFR3 alterations than metastatic disease. We see it in up 70%, 80% even of the low-grade tumors, all the way up to metastatic disease where it's probably 15 to 20%. Now, the other interesting fact is upper tract is different than lower tract, even though they're both urothelial cell carcinomas. The FGFR3 alterations and deletions and mutations are seen more commonly in the upper tract. Unfortunately, we learned a painful lesson with our Proof 302 trial that was designed to test the adjuvant infigratinib, which is FGFR3 inhibitor, in the adjuvant setting, which requires a lot more patients. And we thought, we were calculating approximately 40-50% upper tract alterations. The reality is more like in the 20% range. So we're still learning, but one of the exciting things going back to non-muscle invasive disease in this intermediate risk population is going back to the 70% for low risk. That's real. I think we're seeing that currently. And there are now targeted therapies for that. We have now, I presented here the oral erdafitinib, cohort 3 for the Thor-2 trial, is showing spectacular responses in a subset of these patients who were getting oral erdafitinib and FGFR3 positive low-grade tumors with unbelievable responses. 87% of the patients had a complete response. So now, of course, we're not going to be using oral erdafitinib in the future, but now it's been placed with the device. We have the TAR-210 device that has the erdafitinib tablets that's placed in the bladder for 3 months, once every 3 months, and the early results are great. And now we have a clinical trial coming up, sort of testing that in a prospective fashion.
I guess maybe I'm going to ask each one of you for the one sort of thing you're most looking forward to in the next 12 months in non-muscle invasive bladder cancer. What's coming, or what change are you most excited about? What data do you want to see or change in your practice?
Honestly, we're going to start with me. Okay. I want to see Sima's biomarker, urine biomarker response.
I think that's more than 12 months.
Yeah. Okay. I'll wait. But no, for me, honestly, it's I'm seeing, first of all, the 6-12 month results. That's what I want to see. But I'm seeing these FDA approvals. That is super exciting to me because that makes the drug available to us. And then we can do these studies that we really want to do in the various spaces without having to have the constraints of a clinical trial. So most exciting for me, FDA approval. We already have one. Adstiladrin's FDA approved, and it's actually available in clinic right now in certain sites. So that's exciting.
Yeah, I mean, I'll piggyback on that. I think I was fortunate enough to serve on the FDA ODAC panel that approved pembrolizumab, and we got a lot of flack because this is a drug that is systemic and it doesn't have durable responses. But when you look at the data, it was still better than the only other approved agent, which was valrubicin. And the idea, at least those of us who were on the committee talking, was, look, if it works, we should approve it. And essentially, it doesn't matter how expensive it is, doesn't matter whether it's going to be durable. The physicians who prescribe the drug will sort that out, and they will prescribe the best drug for their patients. We need to put the burden on our physicians to choose the right drug for their patients. So now it's exciting. Now we have that as a benchmark, and now every drug that's coming along is walloping that previous benchmark. And as a result, pembrolizumab is not being used. But I think it's this is finally the time of bladder cancer. We had prostate cancer has all these drugs, kidney cancer, and now we're finally in the space. And then one thing we didn't talk about that I think is really exciting is photodynamic therapy, photosensitizer therapy. That's making a comeback with some novel trials that are now up and running. So I think it's really the best time to focus on bladder cancer.
Dr. Porten, I left you the unenviable third position here.
I think the other thing that should be starting to report some results, hopefully in the next year or so, is the cysto study, which is sort of looking at this question from a different way. If you're looking at patient and caregiver perspective, and then also there'll be clinical outcomes on how physicians and patients make the decisions, and how you can see how that could impact quality of life, and maybe that can inform how we can help our patients figure out the next best option, right? And so I think that's going to be really exciting and powerful as we kind of foray into the next 10 years of hopefully 1 million different therapies.
Absolutely. Yes. I want to thank you all for your time, and it's been a really great conversation, really wonderful to learn from your insights and expertise.
Thank
Thanks
you.
so much.
Thank you so much.
That's great. Thank you.
All right. I hope that's been both interesting and informative for you, and we have much to look forward to as a field, and in the next 6 to 12 months, hopefully we'll have a lot more options for our patients with non-muscle invasive bladder cancer.